Assalamu alaikum everyone. Next topic of discussion is Polycythemia Vera. Epidemiology is it's more common in individuals greater than 60 years of age and risk factor. These all are the risk factor: old age, male sex, white race, hypertension, diabetes, obesity, hyperlipidemia, smoking. Pathophysiology, so there is JAK2 genus kinase 2 mutation, JAK2 oncogene which code for non-receptor tyrosine kinase in hematopoietic progenitor cell. JAK2 is essential for the regulation of erythropoiesis, thrombopoiesis, and granulopoiesis. 98% of patients with polycythemia vera have mutation in the JAK2 gene, and this is the gain of function mutation. So, increased tyrosine kinase activity, erythropoietin independent proliferation of the myeloid cell line, increased blood cell mass, erythropocytosis, thrombocytosis, and granulocytosis. Hyperviscosity and slow blood flow, increased risk of thrombosis and poor oxygenation. What will be the clinical feature? It's often asymptomatic. Non-specific symptoms like fatigue, difficulty concentrating, insomnia, abdominal pain, constitutional symptoms like weight loss, sweating, hyperviscosity syndrome. There will be triad of mucosal bleeding, neurological symptom, and visual changes. Plethora flushed face with purple heave, cyanotic lips. Cyanotic lips are due to increased hemoglobin level associated with polycythemia. Paradoxically, result in cyanotic heave to the face and lips because of the increased deoxygenated hemoglobin concentration, that is 5 gram per deciliter, even without hypoxemia. Then we have pruritus. Itching typically worsen when skin come into contact with warm water. It is also known as aquagenic pruritus. Then another finding will be erythromelalgia, which is intermittent hyperperfusion of the feet and less frequently hands, that is associated with intense burning, erythema, warmth, and swelling. Non-specific neurologic symptoms like dizziness, headache, visual disturbance, tinnitus, hypertension due to hyperviscosity. There will be splenomegaly associated with early satiety and abdominal discomfort, less commonly hepatomegaly as well. Peptic ulcer disease due to histamine-related acid production. There will be gout due to hyperproliferation of the cells and symptom of thrombotic and hemorrhagic complications. So the patient with polycythemia are at increased risk of thrombosis and bleeding. These are the findings of erythromelalgia, hand and feet. These pictures are also showing the finding of erythromelalgia, which is hyperperfusion and flushing. And this is the picture of gout tophi. Now diagnosis: so suspect polycythemia vera an individual with elevated HP and or hematocrit and normal oxygen saturation. Patient with feature of complication associated with polycythemia vera like hyperviscosity, which present with mucosal bleeding, neurologic symptoms, and visual changes, and splenic vein thrombosis. Rule out other causes of polycythemia and other confirmatory studies. What are the confirmatory studies? Serum APO level and a peripheral blood screen for JAK2 mutation. These two are the confirmatory studies. You can also do the bone marrow studies, confirm diagnosis based on the diagnostic criteria for polycythemia vera. Erythrocytosis associated with normal oxygen saturation and decreased APO level are strongly suggestive of polycythemia vera, while erythrocytosis associated with elevated APO or decreased oxygen saturation suggests secondary polycythemia caused by chronic hypoxia. Diagnostic criteria: so we have major criteria and minor criteria. In major criteria, we will have erythrocytosis, increase RBC as evidenced by any of the following: increase HB greater than 16.5 male while greater than 16 in female, increase hematocrit greater than 49% in male while greater than 48% in female, and increase red cell mass greater than 25%, the mean normal predictive value. JAK2 mutation and bone marrow study showing trilinear hematopoietic proliferation, erythropoiesis, granulopoiesis, megakaryocytosis. In minor criteria, we have decreased APO. An elevated or normal APO in an individual with increased RBC suggests secondary polycythemia, not polycythemia vera. Then we have diagnostic confirmation. So all three major criteria are present are JAK2 mutation is not detected in major criteria, but two major criteria plus minor criteria are present. So this is the diagnostic criteria for polycythemia vera, that you have all three major criteria are you have absence of JAK2 mutation detection, but two major criteria plus minor criteria are present. Additional diagnostic points: CBC, you will have normal or increased platelets, normal or increased leukocytes. ESR decrease or normal. Decreased ESR less than 2 mm per hour is highly specific for polycythemia vera but has low sensitivity. Peripheral smear, you will have normocytic normochromic RBCs. If iron deficiency anemia is present, microcytic hypochromic RBC will be there. Serum iron study, so you will have decreased iron, decreased ferritin. So a highly specific investigation means that if the result of the investigations come positive, so it means that you have the disease. A highly specific investigations confirm the disease. But if the results come negative, so it doesn't mean that you don't have the disease. You have to do further investigation. While a highly sensitive investigation means that it can rule out the disease. If it comes negative, so it means that you don't have the disease. But if it comes positive, so it cannot confirm the disease. You have to do further investigation for the confirmation of the diagnosis. Polycythemia vera may manifest with erythrocytosis alone or in greater than 50% of patients, erythrocytosis in combination with leukocytosis and or thrombocytosis. In patients with polycythemia vera and iron deficiency anemia, microscopic finding of IDA, for example, microcytic hypochromic anemia, are seen on the smear, but with elevated HB rather than decrease. So HB will be elevated here. Microcytic erythrocytosis is only associated with polycythemia vera, beta thalassemia trait, and hypoxic erythrocytosis. Now in differential diagnosis, so we have two types of erythrocytosis: absolute erythrocytosis, relative erythrocytosis. Absolute is caused by increased RBC production and there is normal plasma volume. It includes primary polycythemia and secondary polycythemia, while in relative, it's caused by decrease in plasma volume while there is normal RBC. In absolute, we have increased RBC while normal plasma volume, and in relative, we have decrease in plasma volume while RBC count is normal or RBC mass is normal. And we have other myeloproliferative disorders as well. Now we have causes of polycythemia. So we have primary cause. In primary, we have bone marrow defect. There will be increased RBC mass and EPO will be typically low and oxygen saturation will be normal and expected plasma volume is normal. Underlying condition: polycythemia vera and primary familial and congenital polycythemia. Then we have secondary polycythemia, which is physiologically appropriate secondary polycythemia. It is due to the physiological response to cellular hypoxia. There will be increased RBC mass, EPO will be increased, while oxygen saturation will be decreased or normal. Expected plasma volume normal or decrease. What are the causes? So with decreased oxygen saturation, we have high altitude and we have hypoxia due to diseases, for example, chronic pulmonary and cardiac disease. And with normal oxygen saturation, the causes are intermittent hypoxia due to obstructive sleep apnea, smokers polycythemia, which increase carboxyhemoglobin level on carbon monoxide oximetry. We have congenital causes, for example, methemoglobinemia. Methemoglobinemia causes increased oxygen affinity, so oxygen is unable to release into the tissue. Then we have hemoglobinopathies with an increased hemoglobin oxygen affinity. So these are the causes with decreased oxygen saturation with normal oxygen saturation. Now we have another type of secondary polycythemia, which is physiologically inappropriate secondary polycythemia. And polycythemia secondary to condition associated with autonomous production of erythropoietin, renal disease that affect the erythropoietin secreting cell and neoplasms. What are the findings? So the plasma volume normal, RBC mass increase, EPO increase, while oxygen saturation is here normal. So in this case, we have autonomous EPO production like liver. In liver, we have hepatocellular carcinoma. In kidney, we have renal cell carcinoma or renal cyst. Renal artery stenosis. In the renal artery stenosis, the kidney increase EPO production in response to decreased blood flow to the kidney. Uterine leiomyoma and cerebellar hemangioma. So these all produce EPO, which leads to erythrocytosis. The third type in secondary polycythemia, we have medications. Polycythemia secondary to medication that stimulate erythrocytosis. So here we will have increased RBC mass. EPO level is decreased in condition where erythropoietin is given, while it can be normal or increased with exogenous androgen. So in case of erythropoietin supplementation, EPO level will be decreased, while in case of androgen, it can be normal or increased. Oxygen saturation will be normal, and the plasma volume can be normal or decreased. What will be the causes? So one is erythropoietin, other exogenous androgen like testosterone and anabolic steroid. Androgen stimulate the production and secretion of erythropoietin, which leads to erythrocytosis. Then we have another type is relative polycythemia. In relative polycythemia, we have increased RBC caused by decreased plasma volume. RBC mass is normal or minimally elevated. EPO is normal. Oxygen saturation is normal, but here the plasma volume is decreased. Causes is severe dehydration, and elevated EPO suggests secondary polycythemia. Treatment approach: so all patients regular therapeutic phlebotomy plus low dose aspirin. Then give the allopurinol for gout, antihistamine for pruritus, symptomatic management. Monitor regularly for complications. High risk patient or low risk patient with persistent symptoms, so start cytoreductive therapy with hydroxyurea and assess the need for anticoagulation. The management focus on decreasing the risk of thromboembolic events, which are the most common cause of mortality in patients with polycythemia. Now reduction of cell counts, decrease hyperviscosity and thromboembolic events. Target hematocrit is less than 45%. Regular phlebotomy in all patients. Procedure is removal of blood 250 to 500 via venipuncture at scheduled interval. Then we have cytoreductive therapy. Indications are high risk and low risk with any of the following, like polycythemia, refractory to phlebotomy, persistent or progressive symptom despite phlebotomy and aspirin therapy. First line is hydroxyurea. Alternative are used in patients who are refractory to or unable to tolerate hydroxyurea, like JAK2 kinase inhibitor, for example, ruxolitinib, pegylated interferon alpha, and busulfan in older patients. JAK2 inhibitors are highly effective in treating the symptomatic splenomegaly. Splenectomy is now rarely required. Do not treat iron deficiency in patients with polycythemia. Maintaining iron deficiency prevents rapid re-expansion of RBC after phlebotomy. Further prevention, so all patients start antiplatelet drugs, for example aspirin. High risk polycythemia, so start anticoagulants, parenteral anticoagulants, oral anticoagulants. Smoking cessation is associated with decreased risk of thrombosis. Patients with extreme thrombocytosis may develop acquired von Willebrand disease. If platelet count is greater than 1 million per microliter, perform a restocytine cofactor assay and consider stopping aspirin if restocytine cofactor is less than 20%. Symptomatic management for hyperuricemia: give allopurinol. Pruritus: give antihistamines, SSRIs, interferon alpha. And for peptic ulcer prophylaxis, give PPI or H2 receptor blocker. Complications: so it has two types of complication. One is thrombotic complication and other is hemorrhagic complication. Thrombotic, we have venous thrombosis, arterial thrombosis. These are all the examples. While in arterial, we have these all are the example of arterial thrombosis. Then we have hemorrhagic complications. So in hemorrhagic, we have petechia, epistaxis, and bleeding gums. Gout due to high cell turnover, so there will be increased uric acid production. And late stages, acute myeloid leukemia or myelodysplastic syndrome. Additional genetic mutation may cause polycythemia vera to transition to other hematologic disease. Post-polycythemia vera myelofibrosis. So this is the fibrotic transformation of the bone marrow. So that's all about polycythemia vera.